Hello everyone, welcome back to the series of lectures in nephrology. In the last session, we had learnt about chronic kidney disease. Today, we will be learning about the management of chronic kidney disease, that is dialysis and renal transplant. So let's begin. So as you all will be knowing, there are two types of dialysis. One is hemodialysis, other is peritoneal dialysis. So what is this dialysis? Dialysis basically refers to the extracorporeal renal support that we give in order to remove the toxins, right? So this can be a hemodialysis or a peritoneal dialysis. So the basic procedure which is there in hemodialysis is that you have an axis through which the blood is removed and the blood moves through a dialyzer. The dialyzer is a machine through which there is exchange of your material and the toxins are removed, and the blood is pumped back to the patient, right? So it becomes a circuit. So the blood goes to the dialysis machine, the toxins are removed and it's pumped back to the patient. In peritoneal dialysis, how is it different from hemodialysis? There is a semipermeable membrane. In hemodialysis machine, the dialyzer is your membrane. Here, what is the membrane? The membrane is your peritoneum. So in this peritoneal dialysis, what do? We basically infuse a dialysis fluid into the peritoneal cavity, and the peritoneal cavity and the dialysis fluid acts as the dialyzing membrane, and the toxins are removed from the peritoneal fluid and moves to the dialysis fluid. So dialysis happens within the peritoneal cavity. So there are certain advantages of peritoneal dialysis over hemodialysis. One thing is that it does not require a machine, so it is not machine dependent. Then it is easier for the patient to undergo peritoneal dialysis. So why is that so? Why is it easier for the patient to undergo peritoneal dialysis? Because hemodialysis basically requires about 3 to 4 sessions per week, and each session is around 4 to 6 hours. So there's a lot of time that is going on, but peritoneal dialysis can be done in the night. It can be done by the patient himself. It does not require any machine. It does not require any much of support. That is the reason why peritoneal dialysis is more favorable. Okay, but there are certain disadvantages of peritoneal dialysis. So what happens is that if you look at the representative diagram, what happens is that there is a peritoneal fluid which is going here, and through this membrane this dialysis is happening, right? So this fluid is very much rich in sugar, right? So there is a chance of hyperglycemia. Apart from that, there is a chance of hypertriglyceridemia. And what are we doing? We have a peritoneal catheter, right? So this is very much within the body, so there is a chance of sepsis and peritonitis. And hemodialysis is more effective as compared to peritoneal dialysis. Okay, so this is your hemodialysis versus your peritoneal dialysis. Now let us understand what are the indications for dialysis. So the indications of dialysis are: 1. Acidosis. You remember it with the mnemonic AEIOU. Okay. So what does A stand for? A is acidosis. E is electrolyte imbalance. Electrolyte imbalance, especially refractory hyperkalemia. Then O stands for overload. What overload? Basically fluid overload. Then U stands for uremia and T stands for toxins. Okay. So this is your AEIOU indications for dialysis, right? So severe acidosis, refractory hyperkalemia, fluid overload, patient is very edematous, not responding to diuretics, presence of uremia, uremic pericarditis or uremic encephalopathy, and presence of certain dialyzable toxins like aspirin or lithium, right? So these are the indications for hemodialysis. Now we have understood what is hemodialysis, what is HT versus PD, and what are the indications. Let us look at the dialysis circuit in more details. So first part of the dialysis circuit is an axis. Okay. So the first part of the dialysis circuit is an axis. So what do you mean by an axis? So the blood has to be removed from somewhere, right? The blood has to be removed from the CKD patient, gone through the dialysis machine, and good blood has to be returned. So that is your axis. So can you see here that there is an AV fistula? That means that the vein and the artery are anastomosed so that the vein also becomes arterialized. So the AV fistula is your most reliable form of your dialysis axis. So most of the AV fistulas are in the left arm. Okay, so your dialysis machine has a pin which goes through that and removes the blood. Okay, and then it passes through the dialysis machine. Then you have a blood pump. The function of this blood pump is that it will pump the blood to the dialyzer. So it goes into this hollow fiber dialyzer. The dialyzer comprises of a large number of fibers and it becomes hollow, and this helps in the exchange. This forms the semipermeable membrane through which the exchange of the toxins happen between the blood and the dialysate. Okay, so the dialyzer has a dialysate fluid which has a composition similar to that of the blood, but there will be some amount of toxins which are lesser. So that urea, for example, goes along the concentration gradient and it has to be removed, right? So the urea concentration in the dialysate will be lower. So this is the basic principle of your dialyzer and your dialysate. Then you have monitors. What are these monitors for? These monitors basically measure or check the pressure. So these monitors basically check the pressure. They also ensure that there are no gas leaks. Okay. Then we have the dialysate fluid. And we have the most important portion, which is your anticoagulation system. Anticoagulation system basically comprises of heparin, where we give bolus heparin every 4th hourly or 5th hourly and so on. Why is this bolus heparin given during dialysis? So that it ensures that the blood does not clot and it goes through the dialysis machine adequately. So the dialysate comprises of this acid bag and base bag. So there is a certain composition of acid and base within the dialysate, so that the dialysis happens and the toxins are removed, right? So this is about the various components of the dialysis machine. So you have an axis, you have a blood pump, you have a dialyzer, monitors, dialysate, and you have an anticoagulation system in place. Once the blood moves through the dialyzer and the dialysis machine, it is pumped back to the patient. Okay, so that completes the circuit. Let us understand about the first portion, which is the axis. So the axis can be of two types. So it can be a temporary axis or a permanent axis. So the temporary axis that we use for dialysis is your central venous catheter. So this central venous catheter can be in your internal jugular vein, or it can be in your subclavian vein, or it can be in your femoral vein. Okay. So basically you have a dialysis catheter which is inserted into your IJV or your subclavian or your femoral. Which is preferred? The right IJV is the most preferred. The right IJV is your most preferred dialysis axis. What about the femoral and subclavian? They can be used, but they are prone to more complications. They are more prone to catheter-related thrombosis. Okay, fine. Now what are the complications? What is the procedure and what are the complications associated with this? So the procedure is that you basically select a vein and you make it USD guided. So the procedure is USD guided. So what happens is that you put a guide wire. So you put a guide wire, and following the insertion of a guide wire, you put the catheter across. Now why is this done as a USD guided procedure? Because just next to the IJV you have the carotid artery, right? So to inadvertently prevent the puncture of the carotid, if the carotid artery is punctured, then what happens? There is going to be complete shut off of the blood supply to the brain, right? So that is the reason why you have to do it as a USD guided procedure. Another very important complication which is associated with this IJV axis is your pneumothorax. So you have to be very, very careful that you do not puncture the pleura while inserting this catheter. Okay, so that is about your CVC axis. But this CVC axis is a temporary axis. You can use it only for about 2 to 3 weeks. Beyond 2 to 3 weeks, there will be a lot of complications like thrombosis, like catheter related infection. like thrombosis and catheter related infection. Okay, so that is about your CVC access and why it is used only as a temporary purpose. Now, if it is used as a temporary purpose, then what are the other types of accesses that you can use? So, the other types of accesses that you can use is your AV graft and your AV fistula. AV graft basically means that this is your artery, this is your vein, and you provide a tetrafluoroethylene graft. Okay, polytetrafluoroethylene graft. So, this graft makes sure that the vein is arterialized. But problem with graft is that it is not quite long lasting. So, the most reliable form of access that we use is your AV fistula. This is a surgical procedure. This is a surgical procedure where your vascular surgeons, they take your radial artery and your cephalic vein and they anastomosis. What sort of anastomosis that we do? We do an end-to-side anastomosis. Okay, so we do an end-to-side anastomosis of the radial artery and the vein. So this makes sure that the vein is arterialized and the overall output becomes very high. So it becomes a high output. Why is that required? Because you need to pump out 500 ml of blood and dialyze it and put it back. That is the reason why you need this AV fistula. Okay, so anytime a CKD patient presents to you, most of the time what nephrologists do is that they monitor the GFR, and as soon as the GFR starts dropping below 30, the CKD is progressing, they start counseling for a fistula then and there. This is what we call as the fistula first approach, right? So that we are all prepared so that the dialysis can be initiated as soon as possible. So before we go ahead and do the fistula, we should always do a Doppler study. A Doppler study is used to assess the caliber of the artery and veins and to ensure that the artery and veins are patent. Alright, if there is calcification, then you cannot do it. An AV fistula takes about 4 to 6 weeks to mature. Right? So how do you know it is matured? When you place a stethoscope over the fistula, you can hear a bruit, right? So if the fistula is going to take 4 to 6 weeks to mature, do you think that a CKD patient will wait for dialysis till then? No. That is the reason why you have these temporary accesses. Okay. So what are the complications which are associated with an AV fistula? The complications is that you can have an aneurysm. You can have some giant aneurysms which develop at the AV fistula site. Apart from that, you can have infections, and over time you can also have a fistula failure. If the fistula fails, then you may have to do a fistula on the other hand. Otherwise, the final definitive treatment will be a renal transplant. Okay. So this is about your dialysis and dialysis access. Now let us understand what is the dialyzer. So the blood flow in a dialyzer is 250 to 400 ml per minute. The blood flow in a dialyzer is 250 to 400 ml per minute. The dialysate flow is about 500 to 800 ml per minute. The processes which are employed in this dialysis machine includes diffusion and ultrafiltration. Okay. So what is the dialyzer machine made up of? It's made up of polysulfone or polyacrylamide. Okay. So that is about your dialyzer. Now let us understand the various complications of hemodialysis. We have understood what is the hemodialysis, what is the hemodialysis circuit, what are the advantages of HD. Now let us understand what are the complications of hemodialysis. Your first complication that you should be aware of is the intradialytic hypotension. Okay. So intradialytic hypotension. So what happens in this is that there is a blood pressure fall of more than 20 millimeters of mercury in the first 30 minutes of dialysis. What is the reason for that? One is a poor cardiac reserve. So if the cardiac reserve is poor in a patient of MI, in a patient of heart failure, if the cardiac reserve is poor, then this can result in intradialytic hypotension. Then if the large volume of fluid is removed, it can result in a fall in the blood pressure. Then no vasoconstriction. For example, if the patient has been on certain medications which are vasodilators, or the patient has taken a heavy meal before the dialysis, then the compensatory response of vasoconstriction is not there, as a result of which the blood pressure falls. So how do you manage this? Most of the time, intradialytic hypotension can be managed with IV fluids, and you take certain precautionary steps. You ensure that the patient is adequately volume repleted, and you ensure that you do not remove that much of ultrafiltrate that it causes hypotension. Okay? And there is also another concept of sodium modeling. What is this concept of sodium modeling? That means that you remove the fluid earlier. You remove more fluid earlier. That means what? More amount of fluid is removed during the earlier portion of the dialysis and not towards the end. Okay. The second most important complication is your muscle cramps. Muscle cramps also occur mainly because of your rapid exchange of sodium or rapid changes in the volume. So again, for this you do what is called as sodium modeling. So more amount of fluid is removed in the earlier session of dialysis rather than in the later session. Okay. Then you can have associated nausea and vomiting during your dialysis sessions. Another very important complication that you should be aware of is your dialysis disequilibrium syndrome. So DDS is dialysis disequilibrium syndrome. So what happens here is that in the first session of dialysis, if the amount of ultrafiltrate that is removed is very high, in the first session of dialysis, if the amount of ultrafiltrate removed is very high, then it results in your DDS or your dialysis disequilibrium syndrome. So what happens here? The patient has a lot of confusion, lethargy and lot of other CNS complications. So how do you prevent this? You ensure that the first session of HD is short. It is only about 2 hours. And also you ensure that the sodium modeling is done. Then let us look at what are these dialyzer reactions. The next complication that you should be aware of is what are these dialyzer reactions. So dialyzer reactions can be classified into 2 types as type A and type B dialyzer reaction. So type A is a serious type of dialyzer reaction where there is an IgE mediated anaphylaxis to ethylene oxide. Ethylene oxide is used in what? It is used in the disinfection of these dialysis machines. So sometimes patient can have an IgE mediated anaphylaxis to that, and it is a very serious complication. So the treatment is like treatment of anaphylaxis. You give them epinephrine and you give them hydrocortisone. And in these situations you have to stop the dialysis. Then type B dialyzer reaction basically occurs 15 to 30 minutes into the dialysis. You can have a type B dialyzer reaction which is characterized by predominantly only chest discomfort. So the treatment is wait and watch. Okay. So these are about the acute complications. What are the acute complications? Intradialytic hypotension, muscle cramps, nausea, vomiting, DDS and dialyzer reactions. What are the chronic complications of hemodialysis? Chronic complications is that 1. You can have predisposition to chronic infections like HIV, hepatitis B and hepatitis C. That's the reason why our CKD patients should be well vaccinated against hepatitis B and hepatitis C. Secondly, what are the other chronic complications? You can have something called as dialysis associated dementia. So this is not very common now. But in the olden days, when aluminium was used in the dialysate, aluminium in the dialysate is associated with a gradually progressive cognitive decline that we call as dialysis associated dementia. The third complication is something called as your dialysis associated amyloidosis. So what happens in this dialysis associated amyloidosis? Now, there is an entity which is called as the flux of the dialysis machine. What is the flux of the dialysis machine? It determines what kind of molecular weight substances are removed. So many a times in certain dialysis machines, there are middle molecules, which means that molecular weight of substances of mid-range molecular weight are not removed, especially beta-2 microglobulin. So this beta-2 microglobulin, when it is not removed over course of time, it accumulates and causes this dialysis associated amyloidosis. So this is about all the complications of hemodialysis. So what have we learned? We have learned what is dialysis, about the dialysis machine, HD versus PD, and what are the different complications of hemodialysis. Alright, so this brings us to the end of the session on dialysis. In the next session, we will be learning about renal transplant.